Ryan Stanton here with ACEP Frontline, joined by Dr. Christina Shenvi. We're talking about something that we deal with a lot. And actually, you have several talks on geriatric and elderly patients as well as new physicians, the first 5 years of practice, but a lot of elderly stuff. And you've actually helped develop a tool for the management of something we deal with a ton in emergency medicine, and that's the delirium agitation of our elderly clientele, those that are at increased risk, not only because of their medical comorbidities, but also risk for falls, risk for sundowning, risk for associated mental status changes from various illnesses that are out there. Let's talk about what you have and how it is going to really give us an extra tool in emergency medicine.
Thanks, Ryan. Well, the tool that we developed is called ADEPT, and that's an acronym that stands for Assess, Diagnose, Evaluate, Prevent, and Treat. And this was put together by a multidisciplinary group in the Coalition on Psychiatric Emergencies. And our goal was to provide an easily accessible tool that you can access on shift. And right now, this is available online at acep.org/adept. And ACEP is working on creating an app for this tool and several others that can be used on shift. And what we're hoping to do with this is to raise the floor, so bring up the standard that of patient care for this entity and help clinicians, because it can be complicated. So we provide some resources and tips and keys for how to assess patients who present for or with agitation or delirium or combativeness or even just a change in mental status, and then how to diagnose what's going on. Say maybe you think they have delirium. What are some tools that can give you a little bit more of an objective slant on whether this is delirium? And then we talk about, for evaluate, what sort of workup do these patients need? And how can you spread a broad net to look for underlying conditions? The issue is that delirium is most often caused by an underlying medical problem. And so it's important when you have a delirious patient to look for what's causing this. Often it's multifactorial and it can be complicated. Then we talk about how to prevent delirium in our older patients. Many places in the country, including my shop, older patients may be in the ED for an extended period of time, depending on bed availability. So what can you do while they're in the ED to help prevent them from developing delirium? This is so key because delirium is an independent predictor of 6-month mortality. And we know that if it's missed, if that diagnosis is not made, that can also have worse outcomes. And then we talk also these things can help for how to prevent worsening of delirium. Say you have a patient who's already delirious, what steps can you take to help them not worsen? And then treatment. This is the real big one. What we don't want is for agitated older adults to be getting, quote, B52'd. We do not want them to be getting 50 of Benadryl, 5 or 10 of Haldol, and 2 of Ativan. That is bad news for an older, frail, delirious, or demented patient. And so we have some alternative treatment options, starting with verbal de-escalation and then moving to oral medications. And we have the doses and potential side effects to look out for on there. And then if you need to, for staff or patient safety, thinking about what IM or IV meds you can use. And again, the doses are much lower than in your 40-year-old patient who comes in agitated and combative. So our hope is that you can pull this up on your next shift when you're thinking about this, or next time you have a spare moment, and review some of the things, think about how this can change your practice on a day-to-day basis.
It's very easy. I've got it pulled up right now on the computer in front of me off the acep.org/patient-care/adept.
Oh, and yeah, you don't even need those extra patient care.
Actually, the way I found it is I just put in ADEPT Geriatric in Google, and it pulled it up. I actually even pulled up the top search was the ACEP page with it on it. And it's easily laid out with each of the headlines, with drop-down menus associated with it, the linked references for each of the tabs. And then interesting, the treatment, because, you know, with your treatments here, a lot of the typical players, but avoiding benzodiazepines if possible, that's one of the challenges we have in trying to address altered mental status, agitation, delirium, in the elderly population. Many times it's just trying to grab fast medications so we can act. And a lot of times that easy button is benzodiazepines, or you reference the B52. But, you know, of course we need to do everything we can to make sure the patients are safe, but we also need to try to prevent from making the problem worse. And especially with benzodiazepines, you can actually make the altered mental status, confusion, delirium symptoms
Exactly.
worse, and increased risk.
You can have problems with the benzodiazepines that it can cause really prolonged sedation, and now you've admitted the patient, but they're so sedated for even up to 24 hours or so. The other problem is that you can actually get paradoxical worsening of their agitation with benzodiazepines in certain patients. And then the problem with Benadryl is it's very sedating, or diphenhydramine, both the sedative effects, and then also it has antihistaminergic effects. And those can be problematic. So unless you're treating an anaphylaxis or allergy, I would avoid the Benadryl. And unless you're treating alcohol or benzo withdrawal, I would avoid the benzos if at all possible.
Interestingly, that ACEP has a huge focus over the last year or two. I mean, it's been longer, but the big push for further focus on the geriatric population with the aging baby boomer population. The numbers of elderly that are entering our emergency departments is growing on a daily basis. Whether it's the understanding of what is available in our emergency departments with that new approval or certification process for geriatric emergency department certification through ACEP, or programs like this that better address, because we've done it for years, decades with pediatrics, understanding they need a little bit different stuff. The environment is different. And so even to the point of making sure that you have certain rooms, but even more often now is completely separating that environment from the adult environment. But now we're seeing that versus the pediatric and middle-aged adult population, there's even things we need to be doing different than with our geriatric population, secondary to the risks, fall risks, ongoing needs risks, comorbidities. Population is living longer, a lot more incidents of dementia-type diagnoses, near and short-term or long-term type diagnoses at various stages. And so those are things that we need to be able to address in emergency medicine to make sure that we're doing everything we can to properly treat and assess our patients.
Absolutely, Ryan. This is just one piece of a much larger effort. And you mentioned the geriatric ED accreditation, which is just went live this year with ACEP accrediting geriatric EDs. I've even got my badge swag that says Geriatric ED Accreditation Ambassadors. But absolutely, this is going to become so important in the next coming decades. The way that we do care right now is just not tenable because the population is changing in ways that are new on the face of the planet. We have never seen population demographics like we're seeing now and will be seeing in the next few decades. And a lot of the push for geriatric EDs is not that you have a separate space. You don't need a separate space necessarily. What you really need is you need to have systems in place to facilitate transitions of care, safe care. You need to have education of your physicians, APPs, nurses about medications, about delirium, about screening for delirium or elder abuse awareness, et cetera, et cetera. So much more important than just the physical space is the systems and the staff that you have.
So let's review once again where people can find all of that information so they can dig into it. They can bookmark the page on their computer. Where can everybody find the information?
Absolutely. So go to www.acep.org/ADEPT, ADEPT, and you can pull that webpage to make it a little icon on your home screen. And if you're interested in finding out more about geriatric ED accreditation, just Google ACEP and GEDA, and that'll take you to the website there that tells you all the information about it. There's 3 tiers. You can be a level 1, 2, or 3, just like with trauma centers. And so it's certainly something that should be attainable at some level to all EDs across the country.
But even if you don't want to go through the process of accreditation, just looking in there and looking, which I know the tools are there in terms of what are the needs, what are the tends to be the things that are missing, everything from just as simple as reading classes and walkers and assistance devices. That's important for you to look at and review. Even if you don't want to go after the accreditation, that's fine. But then being able to understand and focus and making sure your emergency department provides the best safety evaluation and outcomes for our elderly patients. How can folks get more information from you? Email, social media, however?
Yes, any sort of way. You can tweet to me at CLShenvi or email cshenvi@med.unc.edu.
All right, so thank you very much. We've quick conversation there, talking with Christina Shenvi about the ADEPT tool. Again, that page, that website, you can Google it with ACEP and ADEPT or looking at ADEPT and geriatrics. It's easy to find, but the page is acep.org/ADEPT. As for me, you can get more information from me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, and at everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.